Good evening. I'm very happy to be with you today to make an update on SARS-CoV-2 on virological diagnostic. I will speak about the diagnosis, and we will see the current recommendations and some alternatives. Then I will discuss the clinical significance of prolonged PCR positivity following recovery. And then I will finish by the update on seroprevalence and the use of antibody testing as a public health tool. So as you know, there are some common COVID-19 diagnostic methods. First, the detection of viral RNA. This detection is used to detect current infection. And the primary method for COVID-19 diagnosis is based on multiple Rtpcr kits that are now available. This technique can give some false negatives that may result from improper sampling or handling, or sometimes because of very low viral load. And SARS-CoV-2 RNA can be undetectable by day 14 following onset of illness in some cases. So this means that the Rtpcr should be done as soon as possible after the onset of illness. Then we can use some serologic tests. They are used to detect past infection, and they provide a delayed but wider window of time for detection. They are useful for COVID-19 surveillance and the identification of convalescent plasma donors. These techniques can give some false negative. Indeed, the different platforms have various sensitivity, and there are also sometimes some false positive due to cross-reactivity, for example, with other coronaviruses. And the main question is, in case of positive, is there a immune protection if people are re-exposed? So now if we look at the IDSA algorithm for RNA testing, as you can see for symptomatic individuals as well for asymptomatic individuals, the recommended test for a diagnosis of COVID-19 is a direct SARS-CoV-2 nucleic acid amplification testing, mainly on nasopharyngeal swabs or nasal or mid-turinate over oropharyngeal or saliva specimen. In case of negative test for people with a high suspicion for COVID-19, you should repeat the testing, and in case of low suspicion, it's not necessary to repeat the testing. So Rtpcr is the current standard test for diagnosis of COVID-19 using nasopharyngeal swabs or other respiratory tract specimens. A variety of RNA gene targets are used by different manufacturers, with most tests targeting one or more gene in the envelope, nucleocapsid, spike, RDRP, or other genes. So after specimen collection, samples undergo RNA extraction followed by a qualitative Rtpcr for target detection, and this test takes approximately 3 to 4 hours. Overall, all the Rtpcr kits that are registered perform satisfactorily with an efficiency PCR of at least 90%. On this slide, you have the results of an independent evaluation to verify the clinical performance of some RT-PCR tests. This research has been carried out in the University Hospitals of Geneva. And as you can see, on these are some examples. And you can see that the clinical sensitivity of these tests are at least 90% and sometimes 100%. And the clinical specificity is very high at 100%. So now, what do we need for more fluid and rapid diagnosis? As you know, today, the virology laboratory are overwhelmed with a lot of PCR tests. For example, in France, we are performing 1 million tests per week. So we have to find some solution to have a more fluid diagnosis. So there are some ways to simplify that. First, by simplifying the test procedure. There are some molecular point-of-care tests that can be run everywhere. There is also the virus antigen detection that can be used. Another way is to simplify the sampling procedure. And saliva, I will discuss the saliva as an alternative sample. And lastly, samples can be pooled for large-scale Rtpcr, and this is the remaining question. So if we look at the rapid molecular test, they have the advantage to have a low complexity. They are rapid, giving a results within 1 hour. Most of the rapid tests evaluated used the laboratory developed RT-loop mediated isothermal amplification, named the RT-LAMP technology. However, they are not available for clinical use in the US, and none of the European approved rapid tests are using the RT technology to date. In different studies, the sensitivity and specificity of this rapid isothermal PCR compared to the standard laboratory-based assay range from 75 to 94%, and the specificity from 99 to 100%. So we miss some studies with a robust number of patients to define the clinical sensitivity and specificity of this rapid test in comparison with the standard test on the same patients. And to date, we have no data on their feasibility in real life. So this is maybe a future option, but we need more data. In addition, the viral antigen detection could be a good option. We can detect viral antigen with some lateral flow immunoassay. As you can see that on the picture, it's very easy to run. They can be performed using Schwab's similar to those currently used in Rtpcr, and they have the advantage to give a result in less than 15 minutes and could be used at a point of care with no need for a lab. However, these tests seem to need a high enough presence of the surface proteins to be detectable. That means that they have a chance of false negatives than PCR tests. And we would need to implement them with a clear guidance on correct interpretation. And the slides we have, so you can see some evaluations of some of these antigen tests. And you can see that the sensitivity is between 60% to 89% with a good specificity. And overall in the evaluations, they show a lower sensitivity than the Rtpcr test, especially for a low viral load. So now saliva could be also a good alternative sample. And there was a study published very recently in the New England Journal of Medicine. They investigated samples from 70 hospital inpatients who had a diagnosis of COVID-19. They had for these patients nasopharyngeal swabs and also self-collected saliva from the patients. And you can see that at time of diagnosis, the first Rtpcr test, there were more SARS-CoV-2 RNA copies in the saliva specimens than in the nasopharyngeal swabs specimens. And they showed also that they found a higher percentage of saliva samples in blue than in nasopharyngeal swabs samples that were positive up to 10 days after COVID-19 diagnosis. After 11 days, however, there were more positive samples in the nasopharyngeal swabs. So saliva specimens and nasopharyngeal swabs they conclude that they have at least a similar sensitivity in the detection of SARS-CoV-2 during the course of hospitalization. In addition, they tested more than 400 asymptomatic healthcare workers with Rtpcr and on nasopharyngeal and saliva samples. And they detected 13 saliva that were positive. And among them, 9 that had also a nasopharyngeal swabs, 7 were tested negative at the same time or later confirmed. So these results show that saliva have some interest. Indeed, it can be collected by the patients themselves. So it negates the need for a direct interaction between healthcare workers and patients. That is a source of testing bottlenecks and the risk of nosocomial infection. And this also alleviates demands for supplies of swabs and personal protective equipment. So given the growing need for testing, these findings provide support for the potential saliva specimens in the diagnosis of SARS-CoV-2 infection. So if we look at the kinetics of the different virological markers, you can see on this slide for the Rtpcr in the nasopharyngeal swabs in blue, that in most individuals with a symptomatic COVID-19 infection, the PCR is detectable as early as day 1 of symptoms, and sometimes early between 1 and 3 days before onset of symptoms. And there is a peak within the first week of symptom onset, and then the positivity starts to decline by week 3, and subsequently becomes undetectable in most of cases. However, we have some cases in the practice of patients with a prolonged PCR positivity following recovery, and that is a very up-to-date questions. Indeed, in some studies, it has been suggested that around 15% of COVID-19 patients are retested positive for SARS-CoV-2 RNA after discharge from hospital. So why we can find this prolonged PCR positivity? Sometimes patients are discharged from the hospital when there are 2 PCR negative consecutively apart 24 hours, but it could be false negative, maybe in relationship with the sampling procedures, the quality of sampling, sample storage, or temperature and time. Another possibility is that this positive signal of viral RNA might be from the dead viruses and only viral gene fragments without active viral replication. And some cases have also reported that in some patients, we can have a delayed virus clearance. For example, patients treated by glucocorticoids therapy, patients who have comorbidities or more than 65 years. So the most important question is, are these patients infectious? There are some reports from discharged patients that were retested positive in China. And in one study, the follow-up results demonstrated that there were no new infected cases from the 104 close contacts to the original patients. And in another study, no single family member were infected by the 4 recovered COVID-19 patients that were retested positive. So there is no clinical evidence of infectivity of those recovered patients with retest positive for viral RNA. There are also some in vitro data showing that there is a relationship between SARS-CoV-2 viral load and infectivity. In this study conducted in Canada, they performed the SARS-CoV-2 Rtpcr on nasopharyngeal swabs, and they tried to isolate the virus from these swabs. They tested 90 samples, and they showed that the virus was successfully cultivated from 29% of samples. And it was very important to note that the positive cultures were only observed up to day 8 post-symptom onset, with a peak at 3 days. And the virus could be isolated only if our viral load was high, with a significant difference between samples with a CT in median at 18 versus 27 that were non-cultivatable samples. So there is clearly a difference between the PCR positivity and the infectivity. This results has been confirmed by this study, showing that the viral culture is only rarely positive for low viral load, for CT values above 25 to 30, and after 8 to 10 days after symptom onset. And in this study, the viral culture was not positive for feces samples. So the question is now, these patients with a CT above 35, for example, are not contagious and thus could be discharged from hospital care or strict confinement for non-hospitalized patients. And this question has been recently raised by the very high impact factor journal, the New York Times, stating that maybe when you are tested positive for coronavirus, maybe you shouldn't be, because the diagnostics are so sensitive that we can face to this problem. And for example, in a lab in New York, they tested 794 among the 794 positive tests with a threshold of 40 cycles. They reanalyzed that, and for example, with a cutoff at 35, about half of those tests would no longer qualify as positive, and about 70% would no longer be judged positive if the cycles were limited to 30. So this is a very important question, and I think we have to state and to give some answer to that, because there are some implications on the contact tracing and for example. So now if we speak about the serum prevalence, you have this very nice website. The name is Rtpcr, and you can find on this website all the seroprevalence studies that has been performed in the world. And if you click on the country, you can see the national estimates. This is a number, for example, in France, with a seroprevalence estimate between 1% and 4% among 12 studies. If we look at this website, we will see that overall the seroprevalence in the world is relatively low, although there are some difference between the populations tested. This is a very nice study from Spain that has evaluated the prevalence of SARS-CoV-2 in Spain. They tested 50,000 participants for IgG serology with a questionnaire. And they showed that the overall seroprevalence in Spain was at 4.6% by immunoassay. They didn't find any difference by sex, and they found a lower seroprevalence in children younger than 10 years. And yeah, as you can see here, there was some substantial geographical variability with a higher prevalence around Madrid, more than 10%, and a lower prevalence in the coastal areas, less than 3%. So in conclusion, the majority of the Spanish population is seronegative to SARS-CoV-2 infection, even in hotspots area. And these results emphasize the need for maintaining public health measures to avoid a new epidemic wave. So these are some serosurvey, but there is an important point because some studies now have shown that there is a decline of the humoral response over time. Indeed, in this study, they tested IgM and IgG 8 weeks after exposure. So they tested people at time of for serology at time of acute phase and then at the convalescent phase, and they showed that 40% of asymptomatic individuals IgG plus at the acute phase became seronegative, and 13% of the symptomatic became negative at time of convalescent phase. So there is clearly a decline of the seroprevalence over time, and they show that similar observations for the neutralizing antibody, with a decline of the neutralizing antibodies over time, as well in the asymptomatic, as well in the symptomatic patients. So in conclusion, the relatively low seroprevalence and its decrease within 2 to 3 months after infections highlight the potential limits of serology for a diagnostic and the need of timely serosurvey. And this can have some implication because, as you may know, there is a question about the possibility of reinfection, And there was recently a case report of a 33 years old man, apparently immunocompetent, who lived in Hong Kong. And this patient had in March 2020, symptomatic SARS-CoV-2 infection with cough and sputum, sore throat, fever and headache for 3 days. He had a PCR positive on nasopharyngeal swabs, and he was discharged after 2 consecutive negative PCR. At this time, he was in IgG negative at day 10. And so several months after, he traveled in Europe and came back to Hong Kong. And then he was tested at the airport. He was totally asymptomatic, but he had a PCR positive. And during the exploration, he had also an elevated CRP, and he became seropositive at day 5. And it was very interesting because they compared the whole genome sequencing of the virus between March 2020 and August 2020. And this is clearly a different virus, a different clade virus. So this case showed that reinfection, this case showed that this case was probably a reinfection instead of a persistent viral shedding from first infection. So in conclusions, for the diagnostic part, Rtpcr is a recommended test for diagnosis of COVID-19 in symptomatic and close contacts for test, track, and trace. This test has to be done on nasopharyngeal swabs, and there is clearly a growing need for testing. So we should find some alternative tests, for example, RT-LAMP, antigen detection, or some alternative samples, for example, saliva, that seems to be a good alternative. And I think we have to make the distinction between diagnostic and large-scale screening, because for large-scale screening, I think we can tolerate some tests with less sensitivity if these tests are more convenient and rapid. However, for diagnostic, we really need a very sensitive test, such as Rtpcr. But these different kind of tests could be very complementary. In conclusion, for the clinical significance of prolonged PCR positivity following recovery, studies shown that it can be found in around 15%. However, there are no clinical or in vitro evidence of infectivity of these patients with a very low viral load and very high CT. And probably these patients could be discharged from the hospital care and strict confinement for non-hospitalized patients. However, there are some particular cases for immunocompromised patients that could be different. And to finish, for the use of antibody testing as a public health tool, indeed, serology epidemiological studies are very useful to evaluate the circulation of the virus and the herd immunity. However, there are some limits. I showed you that there is a decrease of seroprevalence and neutralizing antibodies within 2 to 3 months after infection. So we really need to be very careful for the interpretation of these studies, and we need a timely serosurvey. This implies also that there is a risk of reinfection, although the description of cases is very rare to date. And this emphasizes the fact that we need absolutely to maintain the public health measures. So thank you very much for your attention, and I will be very happy to answer to your question.